Okay, so this is the Garland type of staining. As we can see over here, you can see that extensive granular deposit. Granular means is like this. Okay, so extensive granular deposits, as we can appreciate, where in the peripheral capillary walls, and they are joining together. They are joining together like this, and they are giving a look as if it is like a garland. Okay, so class 1, if you see the lupus nephritis class 1, immunofluorescent microscopy shows delicate mesangial positivity for IgG, although no abnormalities can be seen by light microscopy. So this is your lupus nephritis class 1, the mesangial deposits. Okay, next we are going to discuss about IgA nephropathy. So as you can classically see over here, the GBM, glomerular basement membranes, they are negative. Okay, whereas if you see, these are the mesangial areas which are showing blob-like deposits over here. Can you appreciate over here? There's a mesangial positivity. So global, and you can see this is the entire glomerulus. The entire glomerulus is showing this deposit. So there's a global deposition, and all the glomerulus is involved. So therefore, we are using the term diffuse. So there is a global and diffuse staining limited to the mesangial areas. So what all you see? Mainly you will see IgA. Along with that, C3, kappa, lambda chain also seen, and lesser amounts of IgG and IgM is seen. Now, myself, Dr. JIBRAN presents to you Simply Pathology, and today we are going to read a very important topic. Today we are going to discuss the role of immunofluorescence in the interpretation of renal biopsy or glomerular disease. Now, it is a very important long answer question asked in your theory exam, and it is also a very favorite examination question, okay, especially for 2024-25 exams. So please pay a lot of attention, because lots of questions are being asked from this particular topic, and it is also a favorite question for examiners, also very commonly asked in your Viva exams. So we are going to start off with the role of immunofluorescence in renal biopsy. Now, before we are going to proceed forward, I would just like you to first go through certain lectures before you try to watch this particular series. So this is basically a continuation of the series. So we have already read in details about immunofluorescence. Okay, so what is immunofluorescence? What are the principles of immunofluorescence? What are the types of immunofluorescence? Okay, what is the working of immunofluorescent microscope, and what are the applications? Okay, we have read in details about them in the chapter of immunofluorescence, that is the part 1 lecture. Okay, and today we are going to see in details of the applications of immunofluorescence in the interpretation of renal biopsies. Okay, so this is the part 2. This is the part 2 of this particular series. Also, it would be very helpful if you first read about the light microscopic findings and the pathology of the different glomerular disease, which has already been covered in details in our series of renal lectures. So we have already read in details about the different conditions associated with nephrotic syndrome as well as nephritic syndrome, as well as we have read in details about SLE in the chapter of immune system in general pathology. So it is highly advisable that before you watch this particular lecture, you first go through the basic pathogenesis and light microscopy findings of the different glomerular disease. So without wasting any time, let us start with today's topic of discussion, that is the role of immunofluorescence in the interpretation of renal biopsy or glomerular disease. So always remember, it is a very rapid and reliable method, and immunofluorescent microscopy should always be correlated with light microscopic findings as well as clinical findings as well as electron microscopic findings if they are available. So in the evaluation of renal disease, immunopathology usually is directed at the identification of pathogenic immunoglobulin, like for example IgG or IgM or IgA, as well as it is directed at detection of complement molecules. Out of these complement molecules, C3 is very important. Others are C1q, okay, properdin, or you have C4D as well. C4D is also there. So depending on whichever disease you are suspecting, you can use that particular panel. So immunofluorescence, it can be used to determine the distribution pattern as well as the composition of the glomerular immune deposits. So wherever inside the kidney, now kidney has many different parts, right? Whether it is present in the inside the glomerulus or it is extraglomerular inside the glomerulus, whether they are affecting the mesangium or the vessels or the glomerular basement membrane, what is the pattern, whether it is focal or diffuse or it is segmental or it is global. Okay, so you have to see what is the location of these immune deposits. Immune deposits means either only antibody deposition is there, or antigen antibody complex is forming which is depositing over there, or along with that complements might also deposit. So the role of immunofluorescence is to determine where these immune complexes are deposited, what is the composition of this immune complex, what is the pattern of involvement, and what is the distribution of involvement. Now there is a routine antibody panel which is used in the evaluation of glomerular disease, which includes antibodies specific for IgA, IgG, IgM, kappa light chains, lambda light chains, C3, C1q, fibrin, fibrinogen, collagen 4 alpha chain. So these are the routine antibody panel that we are using for the detection of these particular. So we are using antibodies to detect these particular substances, either IgG, IgA, IgM, kappa, lambda, C3, C1q, fibrin, fibrinogen. Okay, so why we are saying antibodies? We will be employing antibodies which are going to recognize and lead to fluorescence. Okay, if for example we have to use antibodies which will detect IgG, antibodies which will detect IgA, antibodies which are specific for IgM, similarly antibodies which are specific for C3 or complement products. So we are actually using antibody against different other antibodies or complement system. Now IgG subclass identification like IgG1, G2, G3, G4 as well as PLAB2R staining, it is helpful in the diagnosis of primary membranous nephropathy. Okay. Now allograft, in case of allograft renal biopsies, so in case you want to diagnose any kind of rejection in case of renal transplants, so C4D is very useful in the diagnosis of antibody mediated acute allograft rejection. Okay, this is the important role of C4D. Now some diseases such as IgA nephropathy and anti-glomerular basement membrane disease, they can only be diagnosed by immunohistology or immunofluorescence method, whereas the diagnosis of other disease is it is confirmed or refined by doing immunohistology or immunofluorescence. Okay, so there are certain diseases where immunofluorescence plays a very important role, and there are certain diseases where immunofluorescence is giving an extra benefit. Okay, so they are actually confirming or refining the diagnosis. So reporting, so whenever you have to report the immunofluorescence report for a renal biopsy or for a glomerular disease that you are reporting, so there are certain norms that you have to follow. So what are those norms? Let us see. So the glomerular and extraglomerular location, the intensity of the deposits, the pattern of staining, they should be observed, recorded and reported. So as I was telling you, so immunofluorescence is helping us in the location, distribution, pattern, composition of these deposits. So over here we have to mention everything. So first of all, in the report, you have to mention about the distribution of the immune complex deposit, whether it is present in the glomerulus or extraglomerular, like for example in the tubules or in the interstitium. Secondly, the location, whether the deposits are in the mesengium or in the capillary wall or both, that is within the glomerulus. What is the location of these deposits? Then the extent. So extent means, as with light microscopic features, in case of immunofluorescence also you are using the term focal or diffuse. So focal, as you know, when less than 50% of all glomerulus is involved, we use the term focal, and when more than 50% of the glomeruli is involved, we use the term diffuse, similar to what we have used or seen in light microscopy. Segmental means when a portion of the glomerulus, that is less than 50% of a particular glomerulus. Okay, remember over here we are talking about a single glomerulus, whereas over here we are talking about all the glomerulus taken together, total glomeruli. Segmental means when less than 50% or a portion of a particular glomeruli is involved, whereas global means when the entire glomerulus is involved. Okay, that is your global. Then you are having pattern of staining. So the capillary wall staining can either be linear. I will show, we have already seen in the lecture of renal biopsy that what a linear pattern of staining looks like, and we have already seen what a granular pattern looks like and what a smudgy pattern looks like. So what are the different patterns of staining that we can appreciate in immunofluorescence? The first pattern is either it is linear or it can be granular. Now granular varieties can either be coarse granular or it can be fine granular. It can either be fine or coarse. Okay, similarly we are having band like, smudgy or patchy staining, which again can be either coarse or it can be fine. Okay, either can be coarse or fine. And lastly, when it is negative, scant glomerular immunostain, then you can report it as negative. So these are the different patterns, okay, of immunofluorescent staining. Then the intensity. So if there is no stain, you gave 0. If there is mild staining, 1+. If there is moderate staining, 2+. If there is severe, excessive or heavy deposits, you will label it as 3+. As well as the antisera which is positive. Okay, so for example, you are using antibodies. So the antibodies are positive for detection of IgG or IgA or COMP3, etc. So whatever you have, whatever antisera you have used against whichever antibodies or complement products, you have to write that antibodies for IgG was positive, or antibodies which were used against detection of IgA was positive. Okay, so you have to also mention about the antisera which is positive. So you have to mention the distribution, location, extent, pattern, intensity of staining, as well as the antisera. Okay, so first, without wasting any time, first we are going to discuss about the post-infectious glomerular nephritis. Now please note one important thing. Over here we are only dealing with the immunofluorescent patterns. Okay, we are not going into the details of the pathogenesis or light microscopic finding or electron microscopic finding, because all these things have been discussed already 2 times. Once in the normal lectures of nephritic and nephrotic syndrome. Secondly, we have also discussed the same in details in case of your, interpretation of renal biopsy. So over here, we are just going to concentrate on the immunofluorescent microscopy finding. So in case of post-infectious glomerular nephritis, what is the kind of deposits that we see? It is coarse, granular, lumpy, bumpy IgG as well as C3, okay, where in the glomerular basement membrane as well as in the mesangium. This is what you get, and this is what you should remember in the exam if you are asked, okay, in one line. In some cases, granular IgA can also be seen, but that is in few cases. But majorly you have to remember coarse, granular, lumpy, bumpy IgG and C3 in the glomerular basement membrane. Now there are 3 important patterns of immunofluorescent deposition in case of post-infectious glomerular nephritis. Now post-infectious, sometimes also called as acute post-streptococcal glomerular nephritis or diffuse proliferative glomerular nephritis. So these are the other terms which are used for post-infectious glomerular nephritis. Okay, so there are 3 important patterns. One is the garland type, one is the starry sky pattern, one is the mesangial type. So what is the garland type? In the garland type, there is staining of the peripheral capillary loops by IgG and C3. Okay, mesangial portion is relatively empty. Okay, mesangial portion is relatively empty in the garland type. This is basically signifying acute glomerular nephritis with a severe proteinuria. Okay, so this is the garland type of staining. As we can see over here, you can see that extensive granular deposit. Granular means is like this. Okay, so extensive granular deposits, as we can appreciate, where in the peripheral capillary walls, and they are joining together. They are joining together like this, and they are giving a look as if it is like a garland. Okay, so extensive granular deposits in the capillary walls, okay, and these heavy confluent deposits gives an aspect of a garland. Hence, this is called as the garland type of immunofluorescence, which is one type of your post-infectious glomerular nephritis. One of the patterns that you see in post-infectious glomerular nephritis. And in which stage do you see this? You see in the acute stage, acute glomerular nephritis. When the post-infectious glomerular nephritis, it is in the acute stage and there is severe proteinuria. In that situation, you see the garland type. Second is the starry sky pattern. This pattern that you can appreciate over here is the starry sky pattern. So over here you see diffuse and irregular deposits of IgG and C3 along the capillary walls, as well as inside the mesangium you will see deposits. So it gives us basically a look as if it is like a starry sky appearance. Okay, this is a starry sky appearance. So there is granular staining in the glomerular capillary walls as well as in the mesangium in a starry sky pattern. Third variety, if you see, the third pattern, immunofluorescence pattern that you appreciate over here is the mesangial pattern, which is characterized by granular deposits of IgG as well as C3, usually with the predominance of C3, are found in the mesangial region mainly, although glomerular capillary wall remains largely negative. So in the first variety, what happened? Glomerular capillary wall was main with some amount of in the mesangium. In the second variety, it was there in both of them equally strongly, and over here mainly in the mesangium plus very less or nil in the glomerular capillary wall. Okay, so if you see over here, as we can appreciate, you can see that the capillaries are not stained. Rather, if you see, there are blobs and dense deposits in the mesangium, as you can appreciate over here. So immunofluorescence is showing a mesangial pattern, but this mesangial deposition is completely granular in nature. So granular deposits are found in the mesangial region, although the glomerular capillary wall remains largely negative. Okay, so this is about the immunofluorescent pattern in post-infectious glomerulonephritis and the three patterns that we see over here. Next, let us see the next important glomerular disease, that is membrano-proliferative glomerulonephritis. Now, there are two types. The number one is the MPGN type 1. It is immune complex variant of MPGN. And the second variety, if you see, is basically a type of C3 glomerulopathy, okay, also called as dense deposit disease. Okay, so this is mainly which is followed in short. So what happens that in the immune complex variant of MPGN, that is the MPGN type 1, the most consistent finding is positive staining for IgG in a fine to coarse granular pattern along the glomerular capillaries with or without mesangial staining. So mesangial staining can be there, cannot be there. So over here, there is a deposition, coarse granular deposits along the glomerular capillary basement membrane. So as you can see, this is the capillary staining. Can you appreciate over here? And one very important thing, can you see it is towards the endothelial side, right? So it is a subendothelial type of deposition. Okay, this much you can make out from here. There is a subendothelial deposit, as you can appreciate, towards the inner side facing the blood vessel. Again over here you can see, right? This is basically a capillary. Okay. And over here on the inner aspect, you are having some deposition, subendothelial deposit. Rather, the concept of subendothelial, subepithelial, it is more clear, okay, when we are seeing the electron microscopy rather in the immunofluorescence. But yet you can make out. So what you can see that in the type 1, there is heavy deposits. There are heavy deposits, subendothelial deposits around the capillary membrane, and at very few areas you can see certain mesangial deposits also. And because of this kind of staining, wherein at the periphery, if you see the glomerular capillary membrane, they are actually staining at the periphery, and the entire lobule, this entire part, the mesangial part, has no staining. So it is giving a lobulated appearance. This is giving a lobulated appearance. Okay, and this lobulated appearance at the periphery is showing ribbon-like deposits. I will show you. Can you appreciate? This is the ribbon-like deposit, subendothelial deposit that we can appreciate. And you can see that only the glomerular capillary wall maximally, at most places the glomerular capillary wall is showing the staining, whereas the entire mesangial part has no staining. So this is giving a very like a negative staining in the lobules, right? So this gives a lobulated picture in case of membrano-proliferative glomerulonephritis type 1 or in the immune complex variety. Okay, so in the immunofluorescence, there is IgG deposition in case of type 1 MPGN, showing ribbon-like subendothelial deposits with negativity in the mesangium, giving appearance of lobes, giving a lobular appearance. This is giving a lobular appearance. Okay, this gives a lobular appearance. So what I want to say is, over here the capillary is staining, mesangial is negative, is completely black. Again over here is like this, again over here is like this over here. Capillary is staining, mesangium doesn't take the stain. So this is basically giving an appearance of a lobulated appearance. Okay, this is again you can see over here hollow is there, so lobulated appearance again over here some lobulated appearance is there. So this is giving a lobulated appearance, although at certain areas certain mesangial deposits can also be seen in the MPGN type 1. Okay, so the lobules stand out as clearly negative zone. As we can see, this looks like a negative zone, so we are calling it as a lobules. They are strongly positive for IgG and C3. C1q and C4 also is positive in few cases. IgM is less commonly evident in comparison to the IgG. So this is about your MPGN type 1 immune complex mediated membrano-proliferative glomerulonephritis, and this is the important or most important immunofluorescence pattern. Now coming to MPGN type 2, as I told you, it is also called as a C3 glomerulopathy or dense deposit disease. Over here, what you see, over here we were seeing both IgG as well as C3 was positive, but over here intense staining mainly for C3 is noted along the glomerular capillary walls, and often they are seen in the mesangial region in a ring pattern. So both the deposition is there in the capillary wall as well as in the mesangial region in a ring pattern. So what is different over here? One important thing is over here you don't see IgG, immunoglobulin, you see complement products which are deposited both in the capillary as well as the mesangium. And this is mainly diffuse as well as global. Early complement components like C1q and C4, they are usually absent in case of MPGN type 2. So this is the MPGN type 2. As we can appreciate over here, this granular, this is all capillary staining, as you can appreciate over here. Whereas this over here, very dark staining at the central areas, again granular to dark staining, and sometimes even forming a ring like pattern, you can appreciate over here. Sometimes, so these are the mesangial deposits. Some areas are forming ring like pattern also. These are the mesangial deposits. So immunofluorescence with antibody to complement 3 in a patient with dense deposit disease. So there is staining of the glomerular capillary wall and also staining in the mesangium of spherical structures, some of which have accentuation of staining at the edges. So they form a ring pattern. No immunoglobulin staining was observed by immunofluorescence. So only the complement was positive, okay, in case of your MPGN type 2 or C3 glomerulopathy. Now, one important thing I would like to clear before I move forward, actually we are mainly reading about that MPGN type 1 and type 2 mainly. So as we have discussed the light microscopic and electron microscopic features mainly. So in MPGN type 1, remember, by immunofluorescence, you are having IgG along with C3, and these might be present, might not be present. But in some cases of MPGN type 1, they will only be positive for C3 alone. In that case, we will call it as C3 glomerulopathy. Okay, similarly in MPGN type 3 also, when only C3 alone is positive, we call it as C3 glomerulopathy. Whereas MPGN type 2 or in dense deposit disease, only C3 is coming out to be positive in most cases. So dense deposit disease is always a C3 glomerulopathy. But MPGN type 1 and type 3, which is only positive for C3, they will also come under the broad heading of C3 glomerulopathy. So remember this point. Okay. So previously there was a division into MPGN type 1, MPGN type 2 or dense deposit disease, and MPGN type 3. Whereas today you are either having a diagnosis of MPGN type 1 or MPGN type 3, or you are having a diagnosis of C3 glomerulopathy, rather dense deposit disease. Okay. So this is what a little change is there, okay, in comparison to historical classification. Next, we are going to discuss about IgA nephropathy. So as you can classically see over here, the GBM, glomerular basement membranes, they are negative. Okay, whereas if you see, these are the mesangial areas which are showing blob-like deposits over here. Can you appreciate over here? There's a mesangial positivity. So global, and you can see this is the entire glomerulus. The entire glomerulus is showing this deposit. So there's a global deposition, and all the glomerulus is involved. So therefore we are using the term diffuse. So there is a global and diffuse staining limited to the mesangial areas. So what all you see, mainly you will see IgA, along with that C3, kappa, lambda chain also seen, and lesser amounts of IgG and IgM is seen. Now in a subset of cases, deposits of IgA are seen segmentally in peripheral glomerular capillary walls in addition to globally in the mesangium, and is associated with more proliferative forms of IgA nephropathy. Now the fundamental characteristic in IgA nephropathy is intense, diffuse, granular to globular mesangial immunostaining for IgA. Positivity is limited in this case to the mesangial areas without deposits evidenced in the capillary walls, usually in IgA nephropathy. If you see that IgA deposits are mainly seen in the glomerular basement membrane, and it is more as compared to the mesangium, it is called as the proliferative form of IgA nephropathy. Okay. The next important type of glomerular disease that we will discuss is the membranous nephritis. Now over here, the immunofluorescence pattern characteristically shows a strong fine granular staining for IgG and less intense staining for C3 along the capillary loops or glomerular basement membrane. So you see there is very little or no mesangial deposits, okay, only the glomerular capillary basement membrane basically mainly, or the capillary loops are stained with immunofluorescence. Okay, so MGN is characterized immunopathologically by IgG granular capillary wall deposits, and in most cases C3 is also present in the same location. Now the finding of extra glomerular deposits favor secondary form of disease. So membranous nephritis can be primary or it can be secondary. So if you are finding deposits in addition to the glomerular basement, in addition to the glomerulus, if you find extraglomerular deposition, then it is signaling towards secondary form of membranous nephritis. Now remember, how do you differentiate membranous nephritis or membranous lupus nephritis? Now if you remember, lupus nephritis, the type 5 variety, WHO type 5, it is the membranous variety of lupus nephritis. And how do you differentiate the membranous nephritis from membranous lupus nephritis? So remember, membranous lupus nephritis is characterized by greater prevalence of positive staining for IgM, IgA, C3, C1q, and in particular intense more than 2+ staining for C1q, okay, versus the primary membranous glomerulonephritis. Okay, now as I have already spoken previously that IgG subclassification is helpful in subtyping the primary and various secondary causes of membranous glomerulonephritis. Okay, next we are going to read about crescentic glomerulonephritis. So in crescentic glomerulonephritis, there are three main types of crescentic glomerulonephritis. Type 1 called as anti-glomerular basement membrane glomerulonephritis, type 2 which is immune complex glomerulonephritis, and type 3 which is post-immune complex variety of glomerulonephritis. Okay, so in the type 1, as you can see, this is the linear variety. It is a linear deposition of IgG along the glomerular basement membrane. So if you see over here, this is linear meaning, if you see, it is very smooth. Whereas over here it is granular. You can appreciate it is like this dot like this. Whereas in the linear variety, if you see, it is like a straight line, very smooth. Okay, this is the linear type. So in the type 1 anti-glomerular basement membrane glomerulonephritis, the characteristic immunohistological finding in anti-GBM glomerulonephritis is linear staining of glomerular basement membrane for IgG, usually accompanied by much lesser amounts of granular to discontinuous linear staining for C3. In the type 2 variety of crescentic glomerulonephritis, it is immune mediated, and wherever you see immune complex mediated disease, you will find the granular deposit. So the characteristic immunohistologic finding in immune complex crescentic glomerulonephritis is granular staining of the glomeruli for immunoglobulin or complement. Whereas in the post-immune variety, you can see the deposits, but they are very light. It is close to negative, characterized by lack of detectable anti-GBM antibodies or immune complex by immunofluorescence. This is the post-immune variety of crescentic glomerulonephritis. Now next we are going to read in details about FSGN, that is focal segmental glomerulonephritis. So this you can see focal and segmental. Focal means less than 50% of the glomeruli, total glomeruli is showing the change. Segmental means less than 50% per glomerulus is showing the change. So there is often segmental glomerular staining for IgM as well as C3 and to a lesser extent of C1q, consistent with non-specific trapping in areas showing sclerosis and or hyalinosis. Less intense and more delicate mesangial staining for IgM and C3 may also be observed involving the mesangium of non-sclerotic segments as well. Okay, so over here you can see in the immunofluorescence, okay, it shows focal and segmental. So a particular segment is involved, and they are showing deposits of IgM over here in focal segmental glomerulonephritis. Next, very important is your lupus nephritis. Now, in very short, I am going to discuss the various stages because we have already discussed in details about the same in the lecture of SLE in the immune system. So class 1 basically is minimal mesangial lupus nephritis, wherein you are seeing mesangial deposition is only seen by either immunofluorescence or by electron microscopy. You cannot see any deposits by light microscopy. When you can see the mesangial deposits by light microscopy, remember it is mesangio-proliferative lupus nephritis. Now remember, as we are going down over here, the deposits are subendothelial. Once you come to class 5, the deposits become subepithelial. Okay, so class 3 is basically focal lupus nephritis involving less than 50% of the glomeruli. Over here, whatever changes you get certain proliferative changes, proliferative endocapillary as well as extracapillary deposits also you will see, and same changes are seen in class 4 variety, but the only thing is it involves more than 50% of the glomeruli. This is the only difference. Then we are having membranous lupus nephritis, and lastly advanced sclerotic lupus nephritis, where more than 90% of the glomeruli they become sclerotic. So these are the 6 important types of lupus nephritis. Okay, next I am going to just show you one very detailed variety or the detailed classification Now this is the ISN RPS classification of lupus nephritis, which is the one which is followed. It has basically modified the WHO and it has made it more detailed. Okay, so I have already discussed in details about this in the immune system lecture, so I am not going to go into the details. Class 1, as you know, minimal mesangial lupus nephritis. So there is mesangial deposits, but it is not seen by light microscopy, rather by immunofluorescence you can detect. Mesangial-proliferative variety, purely mesangial hypercellularity of any degree or mesangial expansion, which can be appreciated by light microscopy with mesangial immune deposits. So there may be few isolated subepithelial or subendothelial deposits visible by immunofluorescence or electron microscopy, but not by light microscopy. In class 3 variety, if you see, it is a focal lupus nephritis variety. So over here, as you can see, less than 50% of all glomeruli is involved. Usually they show typically focal subendothelial immune deposits with or without mesangial alteration. But remember one thing, it is divided into three main parts. 3A means where they are focal proliferative, that is active lesion. 3A by C is active coexisting along with the chronic lesions. So focal proliferative as well as sclerosing lesion. And type 3 variety over here is type C, which is a chronic inactive with glomerular scars, that is focal sclerosing lupus nephritis. Now, if whatever changes you see over here, if you see in more than 50% of the glomerulus, it becomes diffuse lupus nephritis. Okay, and diffuse lupus nephritis, that is class 4, it is again subdivided into segmental as well as global. So segmental is the term. Diffuse segmental means when more than 50% of the involved glomeruli have segmental lesions, and diffuse global means when more than 50% of the involved glomeruli have global lesions. Segmental is defined as a glomerular lesion when a single glomerulus, that is involving less than half of the glomerular tuft. For example, this much is involved by the disease. This is segmental. But for example, in a glomerulus, this entire part is involved, then it becomes global. So I hope it is clear the difference between global and segmental. Okay. So class 4 can again be segmental as well as global, and again, just like the focal variety, it can either be active as well as chronic, or it can be only chronic. Then the class, and this is also showing subendothelial, diffuse subendothelial immune deposits. Over here the deposits were focal, over here they are diffuse. Class 5 is membranous lupus nephritis. Remember, over here you are having global or segmental subepithelial immune deposits or their morphologic sequel seen by light microscopy and confirmed by electron microscopy as well as immunofluorescence with or without mesangial alteration. And in class 6, advanced sclerosing lupus nephritis, where 90% or more of glomeruli is globally sclerosed without any residual activity. So this is in detailed discussion about the different types of lupus nephritis. Now coming to the immunofluorescence part. So class 1, if you see the lupus nephritis class 1, immunofluorescent microscopy shows delicate mesangial positivity for IgG, although no abnormalities can be seen by light microscopy. So this is your lupus nephritis class 1, the mesangial deposits, okay, positive for IgG. Second one is